Hi, my name is Elizabeth Hart. I'll be doing an assessment of the abdomen.
My name is Scott Hart, and I consent to be in this video.
Okay. So you're going to start with the patient laying on the bed or stretcher. Obviously, that's not the case right now, but with their knees up in a relaxed position, you want their hands at their side. You could place a pillow under the knees as well instead of having them prop their knees up on their own. Next, I'm going to ask the patient to pull up their gown or shirt, and so we can bring it up to right under the breast, just exposing the abdomen. When you're doing an abdominal assessment, you want to make sure that the patient already has an empty bladder. If they did need a urine specimen, you could have given them a urine cup beforehand, and then make sure the room isn't too cold so the patient isn't guarding their abdomen because of that. You want your hands to be warm, and you want your stethoscope to be warm as well, so it's not causing the patient to tense up while you're doing your assessment. First, I'm going to inspect the abdomen, just looking at the contour of the abdomen. This patient's abdomen is flat. A normal contour would either be flat or rounded. Then I'm going to look at the symmetry of the abdomen, noting that it is symmetrical, the umbilicus is midline, looking at the hair distribution on the abdomen as well. Then I'm going to begin and look at the smoothness of the abdomen, noting that there's no obvious scars, lesions, anything like that on the abdomen. I'm going to look at the skin color, noting that it's uniform across, and I'm going to look at the patient's demeanor as well, that they're relaxed, not guarding, etc. Then I'm going to begin by auscultating. We auscultate first so that we're not disturbing the bowel sounds with our percussion or palpation. So I'm going to begin in the right lower quadrant, auscultating clockwise, listening for bowel sounds. The bowel sounds are generally 5 to 30 bowel sounds a minute. Varies based on the patient. The bowel sounds will either be present, hypoactive, or hyperactive. There's no need to count the bowel sounds, but just to note that they're present and how they are there, whether they're acting up or they're very minimal. And you place the bell of the stethoscope on the patient's skin very lightly. And his bowel sounds are active. In this case, you would be able to listen. If you weren't hearing any bowel sounds, you'd want to listen to up to 5 minutes in whatever quadrant you were in, noting that you listen for 5 minutes and there are no bowel sounds, or there is a very minimal presence of bowel sounds after 5 minutes of listening. Next, I'm going to, while doing my auscultation of the bowel sounds, I can also auscultate for any vascular sounds. Normally there should be no vascular sounds noted, but this is an important assessment to do on a patient, especially if they have hypertension. So here I'm going to just listen. After auscultating the abdomen, we're going to move on to percussion. We're going to start by percussing the abdomen. Normally there would be tympany within the abdomen. That would be normal. If we did note any dullness, that would be in an area that has fluid, has any bladder distension, adipose tissues, or a mass that would be dull. So we're going to start off, and we percuss similar to the way that we would percuss the lungs. And you start just at the top of the abdomen with pressing in your middle finger, and you knock with your more dominant hand. If there was any dullness noted, that would be indicative to look further into that area of the abdomen. Next, you're going to percuss for the liver. The liver is in the right mid-clavicular line, so right about here would be our liver. We're going to look and we're going to see that there is no obvious distension, no obvious bulging of the liver here. So when we're going to percuss for the liver, we're going to begin in the area of lung resonance, which would be up here, and percuss down to an area of more dullness. And assess the change in the quality of the percussion. Next, we would assess for splenic dullness. In this case, it's in the left 9th to 11th intercostal space in the mid-axillary line. So we're going to come over here, and in the 9th to 11th, and we're going to be able to percuss for our splenic dullness. Next, we're going to palpate the abdomen. Starting with light palpation, we're going to take our hands with our 4 fingers very close together and just press in about 1 centimeter into the patient's abdomen, just going around, making sure that we're lifting our hand between each palpation instead of just dragging it across the patient's skin. At this point, you want to also look at the patient's facial affect, noting if there's any obvious discomfort, making sure that we're assessing all 4 quadrants. We're going to assess for any muscle guarding, if it's voluntary muscle guarding because the patient's ticklish or because they're cold. You want to note that as well, but you also want to note that if they tense up or they're kind of putting their hands up to guard you as well. That would be a red flag for some kind of discomfort in the area. After the light palpation, you're going to want to move on to a more deep palpation, which is 5 to 8 centimeters. Same thing, taking our 4 fingers, and now this time we're going to move clockwise, just palpating slightly deeper, noting that there's no pain in any parts of the abdomen. And we're moving clockwise for all of our assessments. And that is the end of the abdominal assessment.